Professor Matthew Maurer is the director of the Cardiac Amyloid Clinic at Columbia University, expert in imaging, outcome, treatment, and cardiac transplantation. And he's going to be talking to us a little bit about symptomatic management of ATTR cardiac amyloidosis. Professor Maurer.
So it's a pleasure to see everybody. I don't have as pretty as slides, even if I was showing them, as the Mayo Clinic, which we're all always jealous about. So it's a pleasure to be here. I was going to talk to you, and I'm going to talk to you about many of the symptoms that all of you have informed me that you experience sometimes on a daily basis and sometimes less frequently. Those include things such as effort intolerance, shortness of breath, fatigue, dizziness and lightheadedness, God forbid, an episode of losing consciousness or passing out, a fall, edema, swelling in your legs, abdominal bloating. I'm sure there are others that you're all kind of nodding your head and recognizing. So maybe we'll start off with some of the basics of effort intolerance and shortness of breath. Many patients with a dysfunctional heart, as we saw before, because the heart's leathery and thickened, they experience swelling in their body, and they, after intake of certain foods, can get very fluid overloaded. That's why we often ask patients with amyloidosis and any form of heart disease to carefully monitor themselves. It's quite a complex thing to do. But we ask you to record on a daily basis, at least at our center, I'm sure many of the others, your daily weights, and note whether your weight changes a significant amount in a short period of time. We give instructions such that if patients experience an increase in their weight of more than 2 or 3 pounds in a day, or 5 pounds in a week. I came up with the latter because a patient of mine came back 14 days later and gained 13 pounds. And I said to him, Frank, why didn't you call me? And he said, you told me 2 or 3 pounds in a day. I only gained 1 pound every day over the last 13 days. So the main message is short-term weight changes in brief periods of time are usually associated with worsening heart failure. And at that point, you need to prompt yourself to be in contact with your amyloid specialist, your general cardiologist, or your nurse practitioner or physician assistant who's helping to guide the management. We utilize diuretics. There are tons of different diuretics that are utilized. There are less potent diuretics, which we call thiazide diuretics, such things like hydrochlorothiazide or chlorothalidone. These aren't very potent. We'll come back to one of them in a minute. And then there are loop diuretics. These are things called furosemide, also called Lasix, because it lasts 6 hours, though many of my patients argue that it lasts way more than 6 hours often. There is torsemide, which is Demodex, which is a more potent diuretic, and I'll explain potency in a minute. And then the final diuretic is Bumex or bumetanide. They differ, those diuretics, in something called their bioavailability. That means how much you put in your mouth and then how much is actually absorbed. So Lasix is actually poorly bioavailable. You can take 80 milligrams of Lasix, and if you're swollen and you have edema in your legs, you may have similar edema in the intestinal wall, and in that circumstance, you may absorb very little diuretics, 8 or 10 milligrams of the Lasix, even though you're taking 80. So you can switch the diuretics to something that's more potent, that is Bumex or torsemide, because they're better bioavailable. More of them is absorbed in a relatively brief period of time. We often combine the loop diuretics, that is Lasix, with the thiazide diuretics. I don't know, has anyone ever taken a drug called metalazone or Xeroxolin? Okay, well, those are the drugs that people use, and I call them the bazooka. If you take this, you're going to spend most of your day in the bathroom and the toilet. And the main, I'd say, message about diuretic management is you try to really restrict your salt intake as much as possible if you can in order to avoid getting fluid overloaded. So I always warn my patients when they're going on a cruise or something like that to be very cautious with the salt intake and at least head to the gym, if not for some exercise, at least to measure your weight. I see some of the slides are up, but if we can show them on the screen down here, that would be helpful because I can't read them from that far away. So this is the shortness of breath and the effort intolerance that we're talking about. Patients often complain of needing a lot of pillows to sleep, or what we call orthopnea. They boost their heads up at night, and God forbid you acutely get shorter breath in the middle of the night. Doctors will ask about that. You bolt upright. It's called paroxysmal, sudden onset, nocturnal at night shortness of breath, as shown in this unfortunate gentleman here. As I mentioned, the swelling and the edema often cause worsening effort intolerance and can be, as I said, a consequence of dietary indiscretion. Many of us use a very simple metric to judge how you're doing, and that is we ask you questions about what your functional capacity is, and as Dr. Grogan said, you're the best judge of how you're doing. And this is the famous New York Heart Association class, in which patients who are doing everything they want to do and have no symptoms are class 1, and patients who are short of breath sitting in the chair doing nothing are class 4, and the difference between 2 and 3 is essentially you're able to do usual activities. Patients have informed me that usual activities is walking 2 blocks or up a flight of stairs. If you can do that, you're class 2, and if you can't do that, you move to class 3. Doesn't look like I could forward. And here's the weight management chart that I was mentioning to you before, that we ask patients to have a little notebook and to adjust your diuretics. And maybe you could forward. Okay, next slide was the diuretics. Could we forward the slide, guys? Okay, and these were the diuretics I was mentioning before, and there's a long list of them, but the key here is, as I mentioned, they differ by their potency and how much is absorbed. And again, be careful about using too many diuretics because you could get very dehydrated. This is a diuretic that I think is highly underutilized in patients with amyloid. These are called mineralocorticoids, or MRAs. The 2 classic ones are spironolactone or alprazolam. They've been shown to be very well tolerated in patients with amyloid. They seem to have a pretty good efficacy in patients who have features that suggest amyloid. And these are data from colleagues across the pond in the National Amyloid Center, where they recently showed that across a large cohort of patients, almost 1,000 who were treated with these agents, irrespective of how their heart pumped or filled, that there was a significant benefit in terms of all-cause survival. And so this is something we try to advocate for patients. We have to be careful. You can't take these medicines if your potassium's too high or if your renal function's too low. Spending a lot of time talking about diuretics, but to be honest, more diuretics are not really a good thing. The more you take, as shown here, unfortunately, the worse the outcomes. And so we're trying to come up with other ways to ameliorate the use of diuretics. And there are 2 agents that we've seen, at least in our center, I'm sure others have too, that are very effective. These are agents called Jardiance and Farxiga. They're called SGLT2 inhibitors. And these are drugs that were designed to treat diabetes, but help you remove salt and water from the body, as well as sugar. And we tested them in a cohort of 87 patients here. You can see mainly who had a wild-type amyloid, average age of 80. And I'll just highlight what happened to patients when they took these over 12 weeks while taking diuretics. You can see in the upper time period, their diuretic dose actually reduced over time. So their diuretic dose, if they were on 80 of Lasix, went down to about 60 or 40 of Lasix. Their weight came down. Renal function got a little bit worse over a transient period of time, but then recovered. Unfortunately, none of the cardiac biomarkers that we heard about from Dr. Grogan got much better, but one saltatory benefit is uric acid went down. And a lot of patients who are taking lots of diuretics have gout. I don't know if any of you have experienced that, but this could also help with that. So it reduces the dose of diuretics, and it may ameliorate long-term any gouty flares. Many patients complain of intermittent palpitations, a sense of an irregular or rapid heartbeat. If the heart goes very, very fast, very, very quickly, it's like a balloon. It doesn't have time to fill. If you think about how you blow up a balloon, you don't take rapid, short breaths to blow it up. You take long, slow breaths. So the faster the heart rate goes, the less chance the heart has to fill. Blood pressure can fall in such patients. And in addition, when you're in an abnormal heart rhythm called atrial fibrillation, which means in Latin dancing, the heart can not contract appropriately, and you can form, God forbid, a clot inside the heart. If that clot were to travel, you could have a stroke. And so anyone with amyloid who has an abnormal heart rhythm called atrial fibrillation should be on a blood thinner. Managing of atrial fibrillation, often patients ask about, well, should I stay in this rhythm? Should I try to get back into normal rhythm? This is a very complicated discussion that patients and providers need to have. This is my simplistic view of it, which is if you're very, very symptomatic and you're very likely to go back into normal rhythm and stay in normal rhythm in the checkbox, I recommend that you try to get what we call cardioverted. But if you are asymptomatic and you're not likely to go into a normal rhythm, then there's not a real reason to pursue that strategy. And there's emerging evidence, you can see here, that patients who have early stage amyloid who undergo procedures that are called ablations to get rid of the atrial fibrillation shown in the top bar tend to stay in normal rhythm for a longer period of time than patients with more advanced disease. So this is a strategy trying to put you back into normal rhythm that we try with early stage disease. This is an emerging construct, which is many patients don't like to take their blood thinners. They bruise a lot. God forbid they have a serious bleeding episode. There's a way you can see in this picture to put a occlusion device in the heart, particularly in the appendix of the left atrium, and block off the blood flow there, which is where most of the clots form. This is advertised on television as the Watchman procedure and others. And this is something that could be considered in patients with amyloid, but there's not a lot of very good data. And this is something, again, that requires a very nuanced decision, I think, with your heart failure doctor, the person doing the procedure, and your amyloid specialist, general cardiologist. Another thing that patients often experience is dizziness or lightheadedness. This is often related to changes in posture. When you stand up too quickly, you can get dizzy or lightheaded because all the blood rushes into your leg and not as much as going to, as my grandmother said, your cupola, your head. It can also happen after a meal. When you ingest, food gets diverted to your gut. So the worst case scenario is go to a restaurant, have a real big bowl of warm pasta, dilate your belly, and then try to run out of the restaurant to grab the cab. And we call that a restaurant syncope. You can end up flat on your back. That's the most common reason, but another reason is abnormal heart rhythms, particularly very slow heart rhythms in patients with amyloid. And there are now, as shown in this diagram, certain risk factors that portend who's likely to get a very slow heart rhythm and ultimately need a pacemaker. And you can see here in red that up to 40% of patients who are in the highest risk may need a pacemaker over a year's time. And so we at our center actively survey for this. We don't want to find out that someone collapsed or fell down. We try to identify the need for the pacemaker sooner. Many older adult males with or without amyloid complain of peeing a lot at night, and a lot of the causes are the diuretics, having heart failure. You can see many of us have, unfortunately, an enlarged prostate or reduced bladder function. There are medications that can contribute to urinating a lot at night, and if your blood sugar is not adequately controlled. And there are a lot of different management strategies that I've listed here. Try to drink a little bit less at night, adjust the timing of diuretics, don't take it when you're about to go to bed, and then there are several other medications that can be utilized for this common symptom that patients note. Here's a patient who has a very cold and blue fingers because of usually poor pumping function of the heart. Obviously, we're doing everything we can to optimize the pumping function of the heart, but for this, if it's debilitating, you can use the gloves, hand warmers, and socks, and try to adjust medicines that might lower the blood pressure too much and impair the perfusion of the hands. I have to spend just a minute talking about my least favorite measurement in cardiology. Maybe my colleagues will touch upon it, but this is the ejection fraction, which is the ratio of how much the heart pumps to how much the heart holds. So here's a normal heart. It holds a certain amount of blood, let's say 100 milliliters, and it contracts down to 30. So 100 minus 30 is 70, and 70 divided by 100 is 70%. That's normal. Here's a picture of someone with amyloid. The walls are thicker, as we heard. The heart still contracts very well. This heart holds 50, and it goes down to 15. So 35 divided by 50, same exact ejection fraction. This is why many patients say, I didn't feel well, I went to see my doctor, and he told me my heart's fine. Obviously, that heart's not fine because it's thickened and can't fill. So a better way to think about the heart in that same example is the cardiac output. If your heart pumps 70 milliliters every beat, and it pumps 70 times a minute, you can get 4,900 milliliters a minute, or about 5 liters of blood. But in amyloid, the heart's only pumping 35, not because it can't pump, but because it can't fill. And as a result, even if the heart were to go faster, say 100 times a minute, the output of the heart would be lower despite the same ejection fraction. So I wouldn't spend a lot of time focusing on your ejection fraction. Some patients also complain of chest pain, or what we call angina. I put in quotes angina because sometimes the chest pain is not that. It's really caused by a mismatch in the blood supply to the heart and the need of the heart muscle, which is thickened to get blood. Sometimes it's actually due to a blocked big coronary artery, not in my experience very commonly, but can be, especially in older adults. But more often, I think it's due to this mismatch between the wall thickness and the stress on the heart that's occurring. I've had many a patient with amyloid, particularly get a coronary stent. I would say that a majority of them, in my experience, don't feel much better after getting a coronary stent, and their chest pain doesn't really go away often. This is something that's often very problematic to manage medically if it's real angina from small blood vessels. And then finally, I do want to emphasize that there's a lot of patients who note that they feel unsteady, they have a peripheral neuropathy, they're balanced, they don't feel secure, and they get what I call loss of self-efficacy. They don't feel comfortable walking, and as a result, they walk less and less, and it's kind of a vicious cycle. So I really think it's important to engage in regular physical activity, try to do some aerobic training if you could. Your walker is your friend, your cane is your friend, it's not your enemy. Utilize it because it'll help you propel yourself a little bit further, and modest exercise has a tremendous benefit. And so I've learned from my patients that there are a multitude of symptoms that are often, but not always, related to the underlying cardiac structure and function and the amyloid. Management of these symptoms really requires a multidisciplinary team, reliance on many other caregivers, and I would often say to my patients, please turn to your spouse and say, hey, thanks for helping out, because they do the yeoman's work. And a lot of lifestyle modifications are incredibly helpful in this particular condition, and maybe you're better than, to be honest, one more pill in the pill box. I do think that we've gotten, as a community, much better at managing these conditions, and the future is quite bright. So thanks for your time and attention.